Welcome to The Explainer. Today we're going to break down a topic that, let's be honest, trips up a lot of medical trainees, but it's absolutely essential for clinical practice: hepatitis B. We're going to take this really complex virus and make it simple, make it memorable. Okay, let's just dive right in. If you've ever looked at a lab report that looks something like this and felt your brain just start to short circuit, you are definitely not alone. It looks like a secret code, but I promise, once you learn the language, it tells a really clear story. So here's our game plan. We're going to decode the serology first, then walk through the different phases of the infection. After that, we'll cover the essentials of treatment: who, when, and how, and we'll finish up with some really key prevention scenarios. By the end of this, you're going to look at these panels with a ton of confidence. All right, first things first, before we can understand the story, we have to meet the cast of characters. Getting a handle on these 5 core markers is the foundation for, well, everything else. Think of this table as your official decoder ring. It all starts with 2 main players. First, you have this surface antigen, or HBsAg. If this is positive, it means the virus is actively present. Simple as that. On the flip side, you have the surface antibody, or anti-HBs. This means the person is immune, either because they got the vaccine or they cleared a past infection. The other markers just add color to the story. The core antibody tells you if they've ever been exposed, and the E antigen tells you how infectious they are. Now, this brings us to the single most important fork in the road you need to understand. Is the infection acute or is it chronic? And the difference boils down to just one thing: time. In an acute infection, the body fights it off and clears that surface antigen within 6 months. But if that antigen is still hanging around after 6 months, that's it. The infection is now chronic. That is the defining feature. So for those patients who develop chronic hepatitis B, the story doesn't just stop there. The virus and the person's immune system get into this long, dynamic dance, and we can actually track it through several really distinct phases. And, why is understanding the chronic part so critical? It's because of this number right here. If an adult gets infected, less than 5% of them will go on to develop a chronic infection. But for a newborn infected at birth, that number skyrockets to over 90%. And that is exactly why preventing transmission from mother to child is such a massive public health priority. So the natural history of this disease plays out in these phases. It often kicks off with an immune-tolerant phase, which is really common in younger patients. In this phase, the virus is just replicating like crazy, but the immune system is kind of ignoring it. So the liver enzymes, your ALT, they stay normal. But eventually, that can shift into the immune-active phase. And this is when the immune system finally wakes up, recognizes the virus, and starts attacking the infected liver cells. That causes inflammation, and that's what makes the ALT go up. So the most crucial distinction for us clinically is being able to tell these 2 phases apart. The immune-active phase, that's when the real damage is happening. You've got a high viral load, elevated liver enzymes, and a serious risk of progressing to cirrhosis. You have to compare that to the inactive, chronic phase. This is when the immune system has kind of gotten the upper hand. The viral load is low and the liver is quiet. And that distinction right there leads us directly to the single most important question we have to answer for our patients. Who do we actually need to treat? And when do we pull the trigger? But before we get to the who, let's just be crystal clear on the why. The goal isn't necessarily to cure the infection, which is really, really hard to do. The goal is to stop the virus from making copies of itself, because if we can do that, we can stop the liver inflammation and dramatically slash the long-term risk of cirrhosis and liver cancer. So, who gets the medication? It's the people whose livers are actively being damaged. We treat patients in those immune-active phases, where both the viral load and the liver enzymes are way up. And this is critical. If a patient has already developed cirrhosis, we treat them. Period. We treat them no matter what their ALT or DNA levels are, because we have to prevent things from getting worse. And the how? Well, thankfully, it's pretty straightforward these days. We have these incredibly effective and really well-tolerated oral antiviral pills, like tenofovir and entecavir. They can shut down the virus for years, even decades, with just a single pill a day. It's really a game changer. Okay, let's wrap this all up with 2 super high-yield scenarios that you will absolutely see on your exams and on the wards: how to stop the virus from waking up and exactly what to do if someone gets exposed. So here's a classic boards question that's also a major patient safety issue in real life. You've got a patient with what looks like a resolved infection, right? Their surface antigen is negative, but their core antibody is positive. Now, they need a really powerful immunosuppressant. What's the big worry here? You're worried about reactivation. The risk really depends on two things, the patient's HBV status and how strong the immunosuppressant is. But the rule is pretty simple. If the virus is currently active, meaning they're surface antigen positive, they need antiviral prophylaxis. No question. And if the virus is dormant, so they're only core antibody positive, but they're about to start a high-risk drug like rituximab, guess what? They also need prophylaxis. It's mandatory. This is how we prevent a potentially fatal liver flare. And what about after something like a needle stick? Well, the protocol is simple and it's really effective. It all comes down to the immune status of the person who got stuck. If they're not protected, you give them a 2-for-1 punch. Passive immunity with hepatitis B immunoglobulin, or HBIG, and active immunity by starting the vaccine series right away. If they are protected, you can confidently tell them they're going to be okay. So, the big takeaway here is that managing chronic hepatitis B isn't a one-and-done deal. It's a lifelong condition. Our job is to figure out which phase a patient is in, start treatment if their liver is at risk, and then monitor them over the long haul to prevent the really devastating complications of this virus. The point is, you now have the framework to go from just staring blankly at a confusing lab report to actually understanding your patient's story. You can interpret the serology, you can stage the disease, and you can make those critical treatment decisions that will protect your patients from cirrhosis and cancer for years, and hopefully decades to come.